Hello, my name is Karen Dinh. I'm a clinical risk program manager as well as a registered nurse. I've been a registered nurse for about 22 years now, and I'm here to talk to you today about suicide prevention and to share with you a call to action. Suicide prevention in primary health care has been recognized widely for over 20 years as a growing problem. And in fact, the need for screening or more advanced screening was recognized. It's been widely published about. But overall, we have not seen a dramatic positive impact on the numbers in the years since. So in the coming slides, I really hope to inspire you to think outside the box and find a way to offer hope in your area of influence. To begin, I wanted to look at a few numbers. Suicide is now recognized as the 10th leading cause of death in the United States. It is the second leading cause of death among 10 to 34-year-olds in the United States. And since the year 2000, there has been almost a 40% rise in the death rate, in that mortality rate from suicide in the state of Texas alone. We have seen a 69% increase in the mortality rate in 20 to 29-year-olds. And in the year 2021, 48,183 Americans died by an act of suicide. At the time of this slide, over 1.7 million suicide attempts were documented in the year 2021. We are waiting for more updated numbers. But I wanted to talk to you about suicide prevention in primary care. We know that almost 45% of those who pass by an act of suicide will have been seen by a provider within 30 days. I have seen a recently published study that suggested perhaps even within 48 hours of that event, a person who passed by an act of suicide may have been seen by a primary care provider. This statistic is what spurred me on a personal level to realize that in primary care, we have an opportunity. In fact, not just an opportunity, but a responsibility to do more. So we began to look at resources that were potentially available, and we found multiple different trainings out there. Many train-the-trainer type programs, some more cost-effective than others. What we chose was the QPR program, or Question, Persuade, Refer, based on the work of Dr. Paul Quinnett. And what we did is we began with a group of gatekeepers, facilitators, those who took an initial training to obtain a certification to then go out and train others. And our goal became to really put tools in the hands of all staff, not just a great screening tool, which we already had, but what we were finding is that the opportunities existed for others on the healthcare team to do screening or to recognize opportunities. And these were our front desk staff, our CMA staff, our surgery schedulers, procedure schedulers, those taking messages off of voicemails, off of the patient portal type of tools, communication tools. They were the ones receiving these messages. And so the thought occurred to us that perhaps there was an opportunity there to arm these frontline staff with better education behind what a suicide, what a threat is, veiled and unveiled, and then perhaps an opportunity for them to start a screening right then, as soon as they've heard that message. So what we have done is really work to educate everyone on the team, from frontline staff to our phlebotomists, our CMAs, all of our nurses, and really empower them to feel more comfortable to have those conversations with patients, visitors, and really with the general public. This conversation could be happening in the grocery store. This could be happening anywhere. This conversation, this opportunity to really get to the root of someone needing help and being able to offer that seed of hope. So at this point, you might be asking, what can we do? What can we do more? We've developed great screening tools. They're built into the EMR. Screening tools are available from Joint Commission. Screening tools are available on the DSHS website, on the 988 website. There are screening tools galore, but the onus and the responsibility may not always fall on the provider. And we began to see results when we were putting the tools in the hands of our screeners, our receptionists, our front desk staff. They began to recognize this person called and left a voicemail. It sounds like they may be in trouble. Escalate that call using an error prevention tool. And then being able to contact non-emergency services. Sometimes we have had more than one documented case where a staff member called 911 for a patient because they had left a message that was deemed concerning to that staff member. The staff member did not hesitate. Let her team lead know, hey, I'm calling 911 for this person because I'm very concerned. There was never a question. Emergency services went out and they contacted the clinic back and let them know that there was a life saved because of that call. So it's not always the provider that can do the screening. Sometimes staff never, patients never get to the provider to have that great screening tool followed. And so knowing your resources, knowing what's out there, what's available in your particular area of influence, where are your clinics? Where are your hospitals? Where are you seeing patients or family members? These may be church members. These may be library patrons. Knowing your resources, knowing where you are and what is around you. Who are the helpers around you? The other thing is to be a myth buster. Absolutely, one of the biggest myths in healthcare is that the provider is the only one that can screen and know that someone is in trouble. And the truth is, anyone can offer hope. Anyone can save a life when given the right resources, when given the right background and education to recognize the opportunity that's in front of you, to throw out that lifeline. Take that opportunity. It could be anyone. It does not have to be a provider. It does not have to be a counselor that saves a life. It may take someone completely outside the clinical realm to realize this person may be in trouble. Let me get them to the next person that can help, to that next resource. So breaking down stigmas, opening the lines of communication, actually saying the words suicide, actually saying it, really making it an opening for this patient or for this person to be able to speak freely and recognize that they can trust you with the way they're feeling right now. When it's darkest, we can see the stars. And that's what I'm calling all of you to be, is to be the stars. Really, with every interaction, we're given a moment to affect a life. The value of this gift, the time, it cannot be overlooked. It's precious and it's priceless. So don't be afraid to ask hard questions, have difficult conversations. And if you knew that saving a life was as easy as asking a question, would you do it? Thank you.